the 36 Scale Community CEO Leadership Series. This morning, we're joined by Marlow Hernandez and Jason Conger, two guests with very interesting backgrounds. And so, as we always begin, I wanted to turn it over to Marlow and Jason individually to introduce themselves and share a little bit about their background and what led them to their current spot in the healthcare market today.
Thanks, Jason. I'll go first, Marlow. I'm an attorney by profession and serial entrepreneur, and also a former member of the Oregon House of Representatives. And in every role that I've had, it seems like I am drawn to healthcare in some capacity. Sometimes as an owner, as an advisor, as a board member, as an executive, and it's, to me, it's fascinating. It's both the good and the bad of our U.S. healthcare system, and so it's become a focus in my life and in my profession, and that, of course, led me to the partnership with Marlow and some other co-founders and our current healthcare company, Soran Health.
Yeah, and so I'm Marlow Hernandez. I'm a physician. Always been passionate about making healthcare better. Began my career by founding and developing a more integrated model of primary care at Cano Health, helping hundreds of thousands of people directly and many more indirectly. Our innovations were adopted by many in the marketplace across several states. However, I became frustrated by my inability to continue to innovate population health solutions. Market also significantly changed for primary care, given runaway medical expenses post-COVID. Therefore, I left Cano in June 2023 and formed Soran Health, along with Jason and others, to provide specialty services at home, focusing on patients with advanced care needs.
Thanks. And just for anyone who may not know, for Cano, can you give Marlow an indication of the size of the company when you were running the business?
Yeah, Cano reached about $3 billion in revenues and 170 medical centers up until 2023. After that, I have limited information. They are still fairly scaled. I think close to about 100 medical centers or so.
Just limited to the state of Florida. When we were there, when we left, close to the same time, it was 6 states with clinics, and I believe in another
40 plus markets,
3 or 4. Yeah,
and close to 400,000 managed care lives.
Great. So in this morning's conversation, I want to spend a little bit of time on Cano, spend a little bit of time on Soran and some broader market trends. But I think an interesting place to start is on the topic of ownership. We spent a lot of time analyzing the impact of different ownership models on outcomes in healthcare, which fit, which work, what the pros and cons of each are, from hospital ownership to independent to corporate private equity-backed MSOs. But it's fairly rare that we have the chance to speak with the leadership of a public healthcare company. And Cano went public during your tenure, and be curious to start this conversation by getting your thoughts on the concept of public ownership in provider-based organizations and your experience of what works and what doesn't, and how it meshes with these provider-based organizations.
Sure. Let me start, and Jason, please, add to what I'm saying. I think public ownership can work. Let's start there. However, the company must have the right capital base and maturity to operate in the public markets in an industry as complex as healthcare. Companies in active growth should wait much longer than their peers in other industries to go public. There's just much more to do for a company in the healthcare sector to be ready for going public. More broadly, in terms of ownership, I think that PE can play a beneficial role, and health systems and other strategic investors through consolidation can also benefit the market. However, it's all dependent on the model. If the model is related to consolidation to attain contractual lift and become more efficient in the performance of services, cost will increase. The benefit will not be there for the patients and the broader market. It's as simple as that. If the model, however, is to innovate new sites of care and modalities of service within value-based capitated contracts or even fee-for-service contracts that aim to provide more proactive care at lower price points, costs will decrease. So how do you get that? It is a function of how that ownership base views the business and their understanding of the business and their long-term orientation or lack thereof. It also is related to the incentives for management, for the ownership base, and the contracts that they negotiate with the payers, with health systems. If you see contracts that are at the very least tier 1 type status for those providers who are able to attain the same or better clinical results at lower price points, whether fee-for-service or capitated, you are going to get measurably better service and better outcomes.
Yeah, I would just sort of echo some of what Marlow said in a sense. There's particularly in value-based care, it becomes, and especially in a risk-taking model, some form of risk, it becomes very, very complex because of various factors that I think probably everybody understands fully, everybody who's participating. It's, the information that you get about claims typically lags quite a bit. And so it's hard to identify real-time trends and respond accordingly. And that combined with the administrative burden of being a highly regulated industry, let alone if you were a public company where the costs literally become exponentially higher. It's the need for scale in order to be able to achieve administrative efficiencies and not end up risking too much or being put in a position where you can't understand the risks, especially. It calls for some consolidation in risk-taking value-based entities. And so the need for capital to do that, to build out that kind of infrastructure is significant and not necessarily easily accessible, without institutional capital or once a company matures enough, perhaps accessing the public markets. So I think there's good and bad, but as Marlow pointed out, if the consolidation is to create pricing leverage or increase volume in a transactional fee-for-service model, that is inherently inflationary, and so the system has to work. It has to be set up in a way that you're competing not just for those types of that kind of leverage. It needs to be in a value-based environment where outcomes, quality are rewarded. Investments in prevention instead of investments in driving more volume of procedures or something like that.
A big part of the corporate MSO market has a concept of provider ownership, and that's key structural component to align incentives across the different stakeholders. Did your providers at Cano have equity in the business, and if so, what was it like to manage a organization of provider-based organization where there's very public information around the market cap of the business, around decision making and governance in the business, performance results in the business? Did that impact the culture in the organization? What did that feel like to manage?
Well, I'll let Marlow answer a lot of that, but let me jump in and just say first, Marlow, because I think this is something you might not say. So for our employed physicians, not necessarily our affiliates, but certainly for our employed physicians, they were given equity incentives from the time that we were a private company and continuing on as a public company. And that sense of ownership and alignment, we believe was very important. And the reason that I wanted to jump in and answer this is because the main reason that that happened, and through some resistance from our capital partners, was because Marlow insisted on it and thought it was important for all the obvious reasons, the alignment of incentives, but also the reward for performance and the sense of having skin in the game as as a key part of the organization, which the providers are. And then with the affiliates, of course, there was always some form of alignment, not necessarily in the sense of direct ownership or equity ownership, but in sharing of shared savings.
Yeah, and I wanted to point out that Cano, since December 2016, was majority owned by a PE sponsor, and then majority owned by PE sponsor plus those in the public markets. So it's not like what you would see in other MSOs, think surgery centers, specialty organizations, where anywhere close to the majority or more than the majority is owned by the provider. So it is a different experience having a relatively small equity stake owned by the providers. Nevertheless, it was much appreciated. I don't think it had an impact other than what Jason mentioned, meaning that important sense of ownership and alignment and continued innovation, doing something greater than yourself. For Cano specifically, given that it wasn't as important part of the compensation as it is in other organizations.
Do you expect to see more IPOs, subject to macro market conditions, but as these MSOs become larger, is it a recommended exit option? Do you expect to see more of that? Or given the complexities that Jason, you mentioned in healthcare, is it just not as conducive to IPO exit? Too complicated?
I think that MSOs can benefit from going public and that kind of exit, quote unquote. It is a question of cost of capital. There are significant recurring costs, as Jason mentioned, that private companies don't have. And that needs to be compared to the cost of equity and cost of debt to grow the company and ultimately fulfill the vision. So MSOs need to be in that Goldie stage of not too much growth, not too little, having the right infrastructure already in place, having the right capital base for the longer term. I think that outside of those specific parameters, which would be highly limited in such a space where there's so much complexity and so much current disruption, therefore hard to see provider companies be at that stage. It is probably best to go to the bigger sponsor route or the strategic route, or just continuing the current ownership structure until you achieve those important building blocks of success in the public markets for an MSO.
Great. I want to shift to another key topic that we focus on, which is that of strategic partnerships in healthcare. And I know Cano had a large partnership with Humana over time that helped the company grow. And there was, I would love to hear a little bit more about the nature of that partnership, how it came about, and what it meant to collaborate with a payer on expanding into new locations, new markets, so on and so forth.
Sure. It's rather simple. So kind of work with Humana and others to build centers and deliver services within those centers in areas of critical need, in areas where there was large underserved populations. It partnered with them to ensure it had the necessary short-term resources to make a real difference. Meaning, be able to serve a meaningful amount of those underserved patients, and offer them the integrated, comprehensive, proactive type services that value-based care is all about. So that's a need that continues to be in the marketplace, albeit primary care is under very significant stress because, as I mentioned, there is a trifecta of post-COVID medical costs continuing to be very high, particularly in Part B, as well as runaway supplemental benefits. And now you have rate changes and some slowness to adapt on the part of the payers. And so there's a need for solutions that were not as simple as, let's just stand up more primary care sites and deliver more comprehensive services there. But I do think that there continues to be and will be in the future a significant need for partnerships between payers and providers of many kinds, not just primary care, where either physical sites or specific services are rendered in order to meet specific population health objectives, and the payers and health systems perhaps are smart to pay for those to invest in those, because at the end of the day, what they would like to achieve is better star ratings, predictable and improved medical margins, and membership growth and retention. And so you don't do that by the conventional standard of the past of I've got a paper network and fee for service and hope for the best. Intense amount of competition and a significant amount of near-term cost pressure that and in our minds spurs even more of a need for partnerships and innovation.
Yeah, I would say we had highly productive, very collaborative partnerships with multiple payers, Humana being by far the largest in terms of membership, and we're completely aligned on the things that Marlow mentioned, quality, membership growth, and medical cost, and that worked really, really well. But there's also always a tension between the competition amongst payers, which Marlow also mentioned, the example of supplemental benefits. That was what I'm thinking of when I say supplemental benefits. There's a lot of things that means, but what I'm thinking of most recently is a monthly flex card that can be used to buy things like food or pet food or supplies for your house, things like that. Effectively a debit card. And the competition between the payers is largely in the form of benefits in Medicare Advantage, and so that competition drives them to compete on these very things. Those, however, are largely non-medical costs that we have as a primary care provider. Cano had no control over, And so it creates a tension between the payer's competitive drive and where that cost logically and properly should be borne. And that's not completely new. I mean, there's other examples I could give of that. So it's a system where there's a lot of aligned incentives that can work miracles, I would say, for the patients, and the overall system cost. But then there's some potential tensions between provider and payer that probably need to be thought through and addressed to to create a complete alignment where those costs and benefits are reasonably allocated between the parties, and no party is bearing costs that are not reasonably appropriate for them and not controllable by them.
Were the partnerships with Humana successful? Did Humana achieve its objectives, and same for Cano Health?
Well, I think they were wildly successful, and again, very collaborative. Like cooperating to identify markets and locations where the need was great and could be addressed well by a partnership between Humana and Cano, and again other payers as well. And so I think both parties' goals were being achieved. Now, I will say that in some of the expansion markets that we went into, it takes time for those markets to mature. Think of a single medical center, for example, in a new market where you don't have any kind of strong brand identity or any patient base or things like that. You're going to have a period of time where you automatically have to assume an OpEx expenditure until you achieve your break even and start turning that location profitable. That does take quite a bit of time, or can, and certainly measured in years. And so this goes back to some of Marlow's comments about access to capital, and and similar to what I was saying about, or what we were saying about MSOs. You need to have reserves, and you need to have realistic expectations about how long you're going to have to invest in a new market in order to have it mature and become probably pretty predictably profitable after that.
So I would absolutely echo what Jason said in terms of the success. Key objectives were met and exceeded basically everywhere where those partnerships occurred. Runway or time combined with the inflationary environment and the aforementioned benefits and some of the rate changes put a lot of pressure, particularly on the provider side in this specific case. But there was great success in meeting patient outcome objectives as well as medical margins in such partnerships. So the question as to what type of partnership, is it an owned model, or is it one where you effectively do some type of joint venture, or one in which you offer some contract concessions? But I think it depends on the specific market and objectives and the supply for it and the current market, as well as the core capabilities of the payer wishing to meet those objectives, so that in the cases where the payer lacks that core competency and does not want to be in it, it makes a lot of sense to do effectively an RFP to have third parties meet that need in some unique way for them, or customized way for them. In situations where they do have that core competency, have that worked out within the structure of a vertical integration, and there's lack of supply or willingness to provide competitive services, then it pushes more toward the owned model. There are I think easy examples where you have like rural healthcare, and you have healthcare deserts, as it's called, sometimes not in rural settings but rather in urban settings, and the payer has little choice but to buy into those. You just have to be careful that his core competency has that worked out internally in the organization. There's other cases where, let's take the primary care example, where there's plenty of supply, and those that are in value-based care or seeking to do value-based care, and are willing to co-invest. That's a great scenario for the payer. So it's more capital light for them, it's de-risked for them. So it depends on a range of factors. There is not a silver bullet or a right or wrong answer. The only thing I would say on this one, just talking more of the medium and long term, and looking out for a healthcare system and fiscal health longer term, we need to ensure that we maintain competitiveness in the marketplace, and that we continue to evolve healthcare to providing better patient outcomes at a lower price point. So when you have health systems or others that are consolidating purely to do more volume of services at higher prices per service, that's obviously not in anybody's interest except for that individual entity. So with that caveat, and it doesn't happen too often, but we are seeing it in some of the specialties, putting pressure overall in the system, and we have to watch out for it at the hospital level, and so on. With that caveat in mind, most other consolidations, JVs, investment approaches, I think are moving healthcare in the right direction.
Thanks. I want to talk a bit about geography and geographic strategy for national MSOs. I think primary care is interesting because it is a specialty that varies meaningfully by geography, both in terms of competitive landscape and reimbursement models. Cano had a chance to expand from its core legacy in Florida to, I believe, 8 states across 34 markets. And I think, Marlow, you mentioned 170 sites at the company's peak. I would love to get your perspective on comparing performance in these states from a primary care perspective, which were successful, which were unsuccessful, and why.
Yeah, so kind of generally enjoy the same success in markets outside of its home state of Florida, markets like Texas, Nevada, Illinois. It's generally a function of just time in the marketplace, maturity of physical sites, and the kind of state-related intricacies. Some just make it just a little bit more difficult to get the right contracts in place to then build the critical mass that you need to cover your fixed costs and go from there. But when you look at medical margins and clinical outcomes, which ultimately will be 100% correlated to financial metrics, Cano enjoyed effectively the same success. There's some market specific elements for us to discuss, like, for example, in Puerto Rico, Cano never operated medical centers. It had an affiliate type model. In California, Cano never had an affiliate model, but rather medical centers. And when you lack being able to get to critical mass, quicker, and there are market specific elements that just make the runway longer. That puts additional pressure. It would be I think several hours of discussion per market to discuss some of that. But to your general question, across some of the largest markets in the country, you have a lot of similarities, and the value-based care model, where you were offering primary care under an aligned relationship with a payer, and you ensure that you're getting that patient proactive connected care. That's going to be successful no matter where it is.
Yeah, I would add to that, when we say MSO, I know it can mean a lot of different things, and I think Marlow and I both look at it through the lens of our experience, which is value-based type contracts, and so we had two different models. One was our ACO REACH, and the other was more traditional, at least for Florida, MSO, and obviously completely different programs, different, one's MA, one's not. But overall, I think in every case, we think of it as offering limited services, mainly related to trying to help providers make gains in terms of patient outcomes and reducing utilization. And that's through the analysis and delivery of information about their patients and their claims and various metrics, and that's really it. So we did. I think Cano did billing for some of its affiliates in Florida, but that was it. We really didn't have like a high administrative service oriented MSO, and always our MSO or ACO REACH or entities were at risk. So we think about it in those terms, and scaling state to state is it was a little bit easier, by the way, with the ACO REACH, because the federal rules sort of dictated how that would work. State to state, in terms of an MSO, a lot of it had to do, there's the obvious costs and barriers of understanding the regulatory realities in different states. In New York, just to pick a random example, you have to register an entity and it's referred to as an IPA, but you have to register an entity to perform the MSO function that I just described, meaning take risk. And so, every state has different rules. That probably is the threshold consideration, but the ecosystem in which you exist is also really important, and that varies a lot, particularly in like, again, I'll pick a random example, but it's an obvious one. The healthcare ecosystem in California, to me, is different than anywhere else, and that's on top of the unique regulatory requirements, like having a Knox-Keene license to take risk, which is a very involved, expensive process to obtain that license. But there's also a lot of intermediaries in the market already that have a significant amount of market power, and so it's I would say, ultimately, Marlow is right. If you're producing better clinical outcomes and you're accomplishing the ultimate goal, you can be successful in any market, because even though demographics are different and people's habits about accessing the healthcare system are different, all in all, it's not that much different. But the existing ecosystem and the regulatory environment is makes it challenging to jump certain states to other states, I would say.
Yeah, and I think, to Marlo's point, I guess it's also a question of timing and patience and how long of a
Yes.
horizon you have to let that play out, which is why, I can imagine it being in the public markets and having that level of scrutiny would have been, at times challenging, given that dynamic. Based on all that, are there any lessons learned or things that you would do differently from a geographic expansion market? Would it be strategy? Would it be more acquisition, less de novo? Would it be a different rate of new market entry? Or do you think that the geographic strategy that was pursued was a strong one?
Yeah, I think go ahead, Jason, and I'll chime in.
Yeah, so I think it was very successful under the original expectation and strategic plan of the company, and that in that, as Marlow mentioned, while there were different rates of maturing of the operations in different states, and there were different threshold costs to beginning to operate in different states. Most of the states by year 1 or 2 of operating there were showing good underwriting margin, and so it wasn't a question of can we be successful in those states. It was a question of time and having sufficient membership to generate the revenue that would be necessary to cover all of the fixed sort of costs and the overhead. And so I think that the strategy was successful with the base assumption that fueling that growth would continue, and there would be adequate capital to continue it. And just in general, the strategy involved a little bit of both. Like you asked, the difference between acquisitions and de novo centers. The weight was heavier on the acquisitions, and that strategy changed in response to I would say investor base pressure after we went public, to emphasizing de novos. And the difference obviously is that with an acquisition, you certainly are likely putting out more capital in the beginning, but you're also generating cash flow from day one. And with a de novo center, you have a much longer ramp to having positive cash flow. And in either scenario, you need capital, but in particular with a lot of de novo centers, especially in new markets, you need a lot of patience and the ability to feed those centers for years until they turn a profit.
The two of you are now partnering again at Soran Health, which is another exciting venture, and would love to hear a little bit about what you're focused on. I know Soran is in the value-based care ecosystem, so would love to hear specifically what the strategy is and how it's different from the value-based care work you did at Cano Health.
Yeah, let me take that. So we're very excited about Soran Health and what we've already accomplished. And in a short amount of time, the idea behind Soran Health comes from the critical need to find new ways to address runaway medical costs. We have reached, as a market and industry, efficiency frontiers in current care delivery. Primary care organizations, health systems, and payers need so-called wraparound solutions, bespoke type of services to meet specific needs in quality ratings and specialty services that are linked to utilization and patient engagement. So Soran Health is designed to meet those specific objectives. The only connection between Cano and Soran is that we wish we had a service like Soran Health when we were at Cano. And in other words, it's a solution we wish we had. We feel that at Soran, we're doing for healthcare what GPS did for traffic. We are collecting data at Soran that has never been collected, analyzed, or integrated to better direct traffic, quote unquote. So to better improve care delivery. So we're providing valuable real-time risk stratification and intervention opportunities without the need for EHR, ENS, or medical claims data. So those predictive analytics and real-time type of summaries, metrics, what we call data enrichment, resulting in specific actionable insights, are informing risk models and care plans. And so we're already being able to show at scale within Florida the improvements to patient engagement, the improvement to medical documentation, to quality ratings, and the link to medical margins. I can summarize it as we're turning certain cost centers into profit centers. For example, home health is a cost center for payers, for providers, health systems. So we're using software and services that home health can actually become a profit center by improving documentation, quality ratings, enrollments, and chronic care management, and decreasing inappropriate utilization.
Yeah, I would just chime in. I mean, Marlo covered it, but certainly I feel like I'll give you my my opinion about kind of the evolution of value-based care. Yeah, in this one respect, there was a period of time where it was the critical skill set for a value-based care provider was probably coding. It was billing and coding, and having a system that enabled that from all the way from documentation in the clinic to submitting claims, and that was the driver for the main driver for success. And it's still critical, but I think we can see the signs certainly over the last year plus that the utilization management, the improvement of outcomes in a effective but also cost efficient way is absolutely critical. And obviously the struggles that many healthcare companies are going through have to do with cost overruns that are macroeconomic, like inflation, and but they also have to do with the squeeze on reimbursement and premium amounts. And I think that has to do, again, it has its roots in the need to find ways to control costs. And so what in concept, what Soran is doing is looking for lower cost sites of care, as well as sites of care that can improve access, like the patient's home. So if you have a homebound patient, they may struggle to get to a primary care clinic, and then also cost effectiveness or cost arbitrage in the form of modality. So if you can use a less expensive, let's say a preventative kind of approach rather than the most expensive intervention, where appropriate, obviously you should do it. And then the third is delivery or provider personnel cost effectiveness or cost arbitrage. And we're heavily focused on, for example, in our data gathering, finding a way to do it that is as fully predictive and is as valuable to create an understanding of population down to individual patient needs without having to bring the patient into a clinic to see a physician unless that is the right way to do it. So like, for example, if we can have a non-provider gather information that will tell us that, or tell the payer that we serve, for example, the risk-bearing entity, that a patient needs some kind of non-medical intervention, and that will have the effect of improving their outcomes, maybe keep them out of the hospital, or even a medical, but not a visit to the hospital, but they need they're at risk for a fall and they need a new pair of glasses, right? And that will reduce the risk for them. Then there's high ROI interventions that can be done based on that data. And there isn't, as far as we know, there isn't a systematic attempt to gather the kinds of data that we aggregate, we obtain through our operations, and then aggregate and analyze to create those kinds of risk stratifications of a population that are very, very real time and very predictive of, for example, who's the most likely to go to the hospital or to go to hospice care, for example.
Does Soran Health have or plan to have a people-driven component to the business, or is it primarily an IT data analytics offering that you're developing?
So
It's go ahead,
it's
Mark.
both. It's both in that we provide full service for those payers that need it. As I mentioned, we work for the payer. We do not provide primary care, continuity of care, or direct clinical interventions. What we do is we provide this. Again, we aggregate this data has never been tapped, collected, integrated, and so on, for case management action, for care management, type action, for care coordination, and there are some on the Bradford procurement side, or other type of enablement that we can directly help provide for these case managers at the payer level, the systems type level, so that they can work with the patients, PCP and other provider. But it's about anticipating. It's about not waiting for an ENS alert when a patient already goes to a hospital, urgent care, or other connected to such systems. It's certainly not waiting for a claims to hit, not waiting for clinical deterioration. Our critical insight has been, and now we have tons of proof, clinical and financial, is that patients have a certain reserve, and that reserve can be demonstrated through their functional status and nutritional status, and by collecting such data along with social determinants of health data and a few others that we have validated, we can create very predictive models, and make available actionable insights that for the first time ever goes into care delivery and can be 30, 60, 90 days ahead of an ENS alert, and 3-4 months ahead of a claims of a claim on the patient, whether it is a Part B or a Part A type claims, specialist or hospital type claim. So and sorry for being long-winded, but some some payers already have more mature care delivery and can collect this data themselves and have networks that can do it for them. Some don't. And so in those situations, we would provide the staff to go and collect and make available the data for their case management or care management. And so in other cases they do, and it's just a matter of just providing the app, the technical, the technology solution as a SaaS, so a software as a service. So we do both models.
Great. All right. With that, Jason and Marlow, I really want to thank you. Very interesting, and enjoyed hearing about your experiences both at Cano and now more recently what you're building at Soran. So thank you so much for a very interesting conversation.